We're back into the studio. It's time for our big stories, and we have the NHIS boss joining the conversation this morning, Dr. Dacosta Aboagye, and he's going to be we're going to be having a full breakfast, a bumper breakfast in terms of the work of the NHIS, what they've been up to, and in terms of our health, what the plan is moving forward. Dr. Aboagye, good morning.
Good morning.
I love your outfit, I must say. The flowing white. Most are watching the cry white room. but it's a lovely outfit. Yeah. Thanks for doing us the honors and for joining us this morning. Mm-hmm. Let me just start from here. If I were to ask you, what is the current state of the NHIS, our National Health Insurance Scheme? We've come a long way.
Yeah.
The teething stages and all that. Where are we? You've taken over from someone I have liked from afar, and you know the person I speak of. Dr. Bernard Okoboy.
Yeah.
He has now been assigned a ministerial role. What is the state of the NHIS?
Okay, thank you. Let me extend greetings to Ghanaians. The NHIS is really doing well. It's good. We have some few challenges, but in the midst of our 20-year history, I think we have served the population very well. I believe that there must be a couple of reforms, especially if you want to achieve the universal health coverage. And we must also do things that will obviously inure to the benefits of the Ghanaian citizen or the people who really need help. So for this reason, there are a couple of things that obviously will be on board in my tenure. My predecessors did well in the last 20 years. They've actually managed it very well in spite of the challenges. So I think I'll also do my best and serve my country well. And I think Ghanaians will benefit from my leadership. Thank you.
I see. What do you think, you inherited? How much would you say you inherited from Dr. Okoboy in terms of, because before him there was Dr. Selby.
Yeah.
I remember coming to interview her in the office once, then Dr. Okoboy, and now. It's said that for a child, you stand or you sit on the shoulders of those who came before you.
Yes.
Where did they leave off? Where are you taking off from?
I think all the CEOs left left the NHIS in good state. I remember, if I start from 2016, there were some outstandings. I think there was about 1.2 billion. I've been reviewing the data, so I know. There were about 1.2 billion that was left by the previous regime. This was actually cleared by my predecessors, obviously from 2017 to now. That is also not to say that, obviously, we do not owe facilities. But at least we've reduced the months that we owe facilities, because there was a whole year of non-payment of claims that amounted to the 1.2 billion. But in our tenure, if you look at us now, last month we paid 171 million to facilities. The lower tiers, we owe them 3 months. But when it comes to the higher tier, we owe them about 5 to 6 months. So we've paid up to November.
Right.
So which means that we continue to engage the Ministry of Finance for us to close the gap. So we are lagging behind in terms of the higher tier, but we are in line in terms of the lower tiers. And this month, we will still be committing to our payments, but we are in talks with the Ministry of Finance to obviously give us funds to bridge the gap between now, obviously to reduce the amounts that we owe. Yeah.
I see. You've already started talking about your debt, and you've also made mention of the fact that, yes, indeed, debt comes with owing certain. Yeah. I remember having a discussion sometime this year, or was it late last year, with an entity pharmaceutical entity.
Yeah.
And the man was in pain.
Yeah.
In terms of the millions, I'm not talking thousands or tens of thousands, millions owed his outfit, for which reason his business, obviously I can't make mention of, his business was literally crumbling, and it had been a long while. And this person was looking for this money to procure, the components for pharmaceuticals and all of that. There are hospitals, medical outfits, reeling on the back of non-payment. Some of them have actually stopped, that. They have stopped allowing people to use the NHIS because they say, look, we'll not get our money now. So they are doing cash and carry. How are you dealing with these issues?
Raymond, thank you. So if you have a contract, Benjamin, sorry. So if you have a contract with someone, okay, you must stick to the agreements, okay? Right. Like I said, and a scheme that is paying between 180 to 250 per month, it's not a joke, and it's not something that we must take lightly. And under the new act, we're supposed to pay promptly. But the fact is, we know the process. It goes through GRA, which obviously they will have to validate before it's transferred to us. So we have contract with the facilities to be paying within 3 months. And like I've said, the lower tiers are majority of our facilities. We are within range. So, I disagree with the fact that they will be charging, but we've met them. And they are saying
But you do know some are doing that.
Wait. We've met the facilities.
Right.
And they are saying that the tariffs are low. Mm-hmm. This is why they are charging. So a team from my outfit with all the stakeholders are reviewing the tariffs. And that is where the conversation should start. So if you need tariff increase, then it means that obviously, once we review the tariffs, which means that we must take into consideration the current economic situation and also, obviously, other factors. So we are doing all that, and we are doing it with the service providers themselves. So when we come up with the new tariffs, for me, it will be morally not right for the facilities to be charging once we start to implement.
Have you come up with the new tariffs yet?
No, it's ongoing.
Exactly.
It's a process.
That's exactly my point. So I'm saying that they are saying as of this point, some of them, I've had people go to medical facilities and come out and tell you, look, it's not working because, and I'm not saying that the NHIS is a fantastic thing. Like no one, you go to the UK, they have their own system. They've got it to a certain level. We aspire to get there. So it's not to denigrate what we're doing, but to look at the chinks in the armor of the NHIS, because in the end, I don't remember the last time I used my NHIS card. I don't. Thankfully, I have health insurance from here, and I'm able to get access to a few things. But there are some people to whom, if they go to hospital, that extra 50 cedis, 100 cedis, 200 cedis is basically life. It's like taking away a whole lot from them. These are the people we're speaking for. So if they go to any medical outlet, I remember I have a friend who was delivering children and all of that. They didn't, there are things they should have, they didn't get them as per the requirements. So I'm saying, are you aware these entities are there refusing to accept the card?
So, Ben, this is why I said there must be reforms, you see. So the question should be, what are we doing in such a way that we stop these illegal charges? You see, so I believe that there must be reforms, as I've talked to you about. You see, if you look at other jurisdictions, they guarantee what we call, like what we do in the petroleum industry, the automatic price adjustment. But if you look at our act stipulates that we should do a yearly review. Okay. But you see, that is not really helping. Because
it's not realistic.
No, it's not. Because if you do yearly review, then it means that when there is spike in prices, then the pharmaceutical industries and obviously they will still be complaining. Right. So I believe that it's time for reforms, and I believe we need to give guarantees to obviously the facilities and the pharma companies by introducing what we call the automatic price adjustment. Okay. So once you do that, then it means that they have some buffer. They have some guarantee that even if prices are increasing, then, so I'm recommending a national tariff review committee that when obviously prices go up, or depending on the economic situation, that committee will actually sit and review the tariffs. Then we start to implement. That will be one of the solutions to curbing these illegal charges. So at the end of the day, yes, it could be that it's happening, but we also need to put our house in order to make sure that we are meeting them in such a way that they will have no right to be charging the patients. And again, I still do not believe that if you have a contract with someone and now that they are in the negotiation table, they shouldn't be charging our clients because we are paying based on the old tariffs that we agreed.
Yeah.
So it's just a matter of, obviously, we waiting for the tariff conversation to finish. Then we start the implementation. And we've covered it under our budget because if you look at our 2024 formula or budget, we have about 30% plus. So it means that we've covered it under the claim. So it's just a matter of we completing the work so that we give them what is needed. But for them charging our clients, I disagree. It is not right. And I think they should desist from that.
I see. Even in spite of the...
Yes, because we have a hardship. Because we have a contract with them. If you have a contract with someone...
But you know, a contract goes both ways. You must show goodwill from both ways.
Yeah, but we've shown goodwill.
If you owe me money,
yeah,
you've not paid me for many months. Sometimes some would say that it may even stretch into over many months. And my contract is to perform X. Your contract or your end of the contract is to perform Y. You are not performing Y. Already, you are giving me cause not to perform X. You do know that contractually.
No, but you see, I told you, majority of our facilities...
No, I want you to answer that question.
No.
You do realize in contract...
Wait, but once put it in context,
you don't
majority
fulfill your
of the
end.
facilities...
This is what happens.
No, we are fulfilling our end because majority of the facilities are the lower tier facilities, and I've told you that we are within range because our contract says that we should pay within 3 months. And even though the Act stipulates that we must pay immediately, it is not realistic. It's not possible for us to do because the money goes to the consolidated.
So that must also change.
Of course, we must do something
the
about
Act
it.
Must be tweaked
of course,
in that regard.
Yes, I believe that we must tweak the Act a little bit because it goes through to the consolidated fund. By the time you validate and everything, you see, the 3 months is even over for Finance Ministry to transfer the money to the NHIS account. So those are the administrative reforms that we need to make sure that we put the scheme in the right footing. So I look at it more of an administrative than as long as the Ministry of Finance and Controller is releasing the funds, the scheme is actually a very good scheme that is really sustainable over many, many years to come.
Right. I just want to bring in this bit. So you say there must be a tweaking of the Act. For example, some of the things are not realistic, which means then that technically they are compelling you to go outside of your contract because the terms in there, the terms and conditions are not favorable. I mean, I understand you.
Yeah.
If we can say that this is what we aspire to, but currently, is it feasible? It is not. Then you also talk about making recommendations about, the scheme moving forward. It is one thing to recommend. It's another thing to actualize. What are you doing? How quickly are you doing it? I mean, how are you going to be able to execute? What is the plan? Okay. What have you initiated?
Thank you so much. So you see, the good thing is in leadership, you are put there to solve problems, right?
Indeed.
And for me, I believe that I should be able to handle this with all the stakeholders. That is why immediately I've told you that the tariff is actually being reviewed.
Right.
And it's not being reviewed by the NHI, it's being reviewed by all the stakeholders.
Right.
So we'll take into consideration all the prevailing circumstances being it. But one of the things that I've also realized is that if you want the scheme to be sustainable, over the years, the scheme has actually been focusing on certain things like curative services. So how do we reform this dynamics in such a way that obviously there's sustainability? I believe that it's time for us to introduce new things on the scheme in such a way that the claims will actually reduce over time. And I believe that we must now focus on preventive health care. In addition to
preventive rather than curative. Don't wait for the thing to happen and try to deal with it.
And
prevent
it. To prevent it. And you see, this is where, if you look at the advanced countries, it is not just by accident that they send you a text message to come for a checkup. They want to reduce the cost of their health services. Yeah. And those are the things we need to do. So within the 2024 budget, we are introducing what we call the annual health check. giving
annual health check.
Yes, giving every Ghanaian the opportunity to go to any of the health facilities to have their vitals checked on their birthday or on their month of birth. In fact, it is really going well. This committee, I've set up a committee chaired by Dr. Aboagye, the former Deputy Director General of the WHO. The partners have actually expressed interest, and because we want to make sure that we reduce our cost burden in such a way that it is sustainable. Our grandfathers told us that prevention is always better than cure. And to be honest with you, it is the best approach that we can go. I speak in conferences, and when I say development partners, and I cited about this, if we are able to introduce it, of which we are starting, we really need to introduce it. See, we are just sitting on a time bomb of the non-communicable diseases, hypertension, diabetes, stroke, and the NCDs. So how do you reduce these? We can only reduce
these are the very ones creating chaos in our lives now. Because hypertension feeds into diabetes, and hypertension feed into kidney disease, and all of it. We'll get there.
Yes.
We'll get there.
So that's why we need a holistic approach in dealing with it. And I think that is what has been missing from our scheme for the last 20 years. So we need to introduce it now in such a way that our claims will now be preventive, curative, and the services. Once you do that, you'll be reducing the cost of the curative services over time. Right. Though initially it could be expensive, but it's okay, because that's how, obviously, in health economics, that's okay. But it will be reduced over time, and Ghanaians will get the full benefits. You get what I mean? Yeah. So I think this is the things those are some of the reforms that I want to introduce immediately to see the scheme, the sustainability of the scheme, and also to see that life expectancy is increased.
Right.
In the Sustainable Development Goal 3 talks about health and wellness. The wellness part is where we need to be focusing. As for, obviously, the wellness part has been missing in action. So we really need to focus on the wellness, and this annual health check will fit into the wellness package that we are.
I honestly, and of course your expertise coming into the role, it's crucial. It's the first time that we're having someone with your background. And I think I like part of where you are headed. And this annual health check I think it's an amazing concept, because I feel if we all were doing this, which is what other jurisdictions do, you will likely not get to the point of terminal illness or all of that, or not even realizing that something as basic as your blood pressure has been shooting up for them to diagnose what the problem is before it becomes problematic.
You are right. Yeah.
But I want to know, what will this cover? Because a checkup is broad. Someone can have a full body checkup. Others can give you just, I'm just checking this and that. For example, a lot of men now are having prostate-related issues. Right? So is it going to be in there? A lot of women, I've interacted with women who would tell you, in fact, I've supported some people who would tell you that, I can't go for the nipple thing. It's expensive. Mammograms. Mammograms. Right. And so some of them will be there. There's a lump or something they are not taking. Before you realize it, then it becomes a cost on the system. Are these things going to be factored in?
Okay. Thank you so much, Ben. You see, I think that we must start from somewhere. I believe that, like I talked about the NCDs, let's look at the basic ones like hypertension, diabetes, for example. Then let's look at body mass index and also weight to start with. It can't always be expanded because you say it also comes with cost. So it must always be. But let me at this point also say that conversation on prostate, for example, have actually started. It's been ongoing. It started from my predecessor's time. So it's actually ongoing. We cover some of the cancers. We cover breast cancer, cervical cancer, 4 childhood cancers, you see. So,
and even the childhood cancers, it was quite a tussle.
Yeah, it was.
Some of us were advocates before, but thankfully some of them.
Now I can confirm that since its introduction, we've paid about $1 million. To clients.
We applaud you for that.
Yes, thank you. In facilities like I can mention them, Agogo Hospital, Gatanga, Cape Coast, Ho, and most of the hospitals that do have these children, we actually covered them. So I specifically requested for this data because obviously it's important we put it into perspective because we are now paying.
Right.
So, and I'm happy that we are able to do that, and even to be able to do more in the coming years when these reforms actually kicks in. But like I said, there must be a holistic approach to, obviously, the NHIS reforms. As I've told you, the pressure to also add on the diseases is also very real. Today, you say HIV, you say add on. This disease will say add on. So let's tackle it from the roots. Once we start to tackle it from the roots, then we know that we'll be getting somewhere. And this is what I really want to champion. And one of the challenges that we've also noted is the informal sector. You see, it has been a big problem since our 20-year history.
Right.
So this comes in with the digitalization agenda of the government, where now your Ghana card number is now your NHIS number.
And I was about to get there, but you started.
Exactly. So. If you are able to do this, you see, I mean, if you go to the facility or any facility using your Ghana card, which we've started because you need to link your Ghana card with your NHIS card. You see, once you are able to do this, then it means that we are actually reducing the barriers to healthcare. And this is what will aid us to the universal health coverage. So this year, NHIS and NIA, we've actually signed an MOU. So on our database, we had about 6.3 million Ghanaians without Ghana card. Instead of printing our cards, which cost between $4 to $6, we are saying that no, we will not print our cards anymore. We will cede this money to NIA, who really needs the resources to print the Ghana card for us. So it's also another bold and
so one card to take care of the entire.
Exactly, one card to take care. Right. Then all you have to do is to remove the cost component, that's the registration fee. Then universal health coverage is on site. Right. You see, so these are the reforms that I'm talking about. And like you said, this is my expertise. So I think it's good that I'm bringing it on board, and it's good that the whole system will actually benefit from these reforms.
So you're also trying to bring in, bring on board 6.3 million children. How far have you gone with that?
In fact, we are starting the mass registration in schools.
Has it started?
No, we're now doing the training. So we've signed the MOU. We're doing the capacity building that goes with it. But we are starting on the June 10th.
June the 10th.
June the 10th. Yeah, we are starting. And the first batch will be registering 3 million of them. And we'll continue to make sure that all the 6.3 are registered. But because NIA do have the funds to do it, it will be easy for them to do it, because at the end of the day, it boils down to the funds. And we are ceding our money to them. So it makes it easy for them to produce the cards for these Ghanaians in such a way that they can access healthcare.
All right. I'll come to another point shortly where I will allow you to talk about. But some say the NHIS is bankrupt. Is that true? Like Musika's sign.
It cannot be bankrupt. Like I've told you, a scheme paying between 180 to 250 million can never be bankrupt. But it's also the case that the Ministry of Finance will release the funds to the NHI. Because once we have constant release, then we wouldn't have problems, and it's sustainable. You get what I mean? So for me,
so what kind of releases do you have? Delayed releases. Exactly. How long does it take? Since you've been there, it's not been too long.
I was confirmed about some few weeks ago.
Exactly.
But I think,
from what you know, from what you've been told since you got confirmed.
We are waiting for them to do the releases. We are waiting for them, but I think they will. The minister has actually assured me that.
Do you think where we find ourselves, IMF, in the grips of the IMF program or IMF supported program, an election year and all of that, do you think it could impact the resources that are thrown your way? And we have the example of experience from the past. So being realistic, are you not being like a bit too much of an Oliver Twist?
Okay, I don't think so. You see, the good thing about the IMF program was that social protection was actually protected. Yeah. So the NHIS, in effect, was actually protected. So in any case, our funds do not depend on the releases from the IMF. Because at the end of the day, you are paying, and I'm paying. So all we know is that our father do have money, and our father should release the money.
We do know, though, just like
so if you've collected,
just like with the Get Fund, you can pay, but sometimes the money will not necessarily end up there.
Social protection is very important. We cannot put the vulnerable in distress. And I believe that the Ministry of Finance will do the needful by releasing the funds to us. I have no doubt to doubt. I have I have nothing, I don't have any doubts that they will obviously release the funds to us to make the payments.
All right.
I have no doubt.
I like your optimism. I know you are communicating something. You are communicating something.
Because of the assurances that have been given to me by the finance minister. So I'm confident that the funds will be released. So I'm confident.
I like something you said. You say we cannot what?
We cannot put the vulnerable in distress. We cannot. We cannot. As a country, we cannot do that. And so we cover most of our claims are for the vulnerable, the vulnerable patients. So we cannot do that. So I think they will stick to that.
I want us to also, I've grilled you a bit. I'll give you a bit of room and then I'll come back. But I also think we ought to celebrate what is going well. So since you've got in, what is going well? What is working well? Effectively, efficiently, that you think we ought to celebrate? What are the gains that the NHIA has made?
Okay, thank you. I think I've already mentioned a lot of gains that we have, but I think what I will obviously say is that we need to celebrate the scheme, and the scheme needs to be supported by everyone. For me, in terms of the workers, obviously for the NHIS, what they go through, and also to make sure that they are delivering on their mandate is really remarkable for the last 20 years. In fact, we were in the Eastern region. Someone said, I've worked in the NHIS for 25 years. Then I asked, when did the scheme start? He said, oh, well, I was there before the scheme. So you see, we need to celebrate the contributions of the workers and also the facilities and our stakeholders for the cooperation and the collaboration that we continue to enjoy with them. It's been going very well. For a very long time, you've seen that even in the midst of, obviously, we not being able to, obviously, for the higher tiers, pay them within the 3 months, they've still been quiet, and we celebrate that. You see, we will just continue to encourage them that they should be working with us in terms of the reforms that are coming on board so that we all can have a very good health system that will benefit the whole of the population. And that is our, obviously, core mandate. We want to serve the population.
Right. Let me bring in a message here from Letitia Osei-Tupoku. She says, it's about screening and not curing the actual disease. Prostate screening annually for males 35 plus is a must, and mammograms for women 40 plus every 10 years, unless there is a family history, is a must. Impact will be felt looking at how much the NHIS is spending on breast cancer, which is covered. Letitia, maybe you missed that angle of the conversation because we spoke about that. I actually put him to the sword on prostate related issues, mammograms and all of that, and he gave an answer. And he also spoke about the fact that we ought to get to the point where we are looking at preventive, not curative strategies. Because once it gets to the point where you now have to cure, then fire is already on the mountain and the country's purse is going to bleed. How many Ghanaians are currently on the scheme as of today?
Okay, so we have about 17 million active members, 17 million Ghanaians. Again, there are certain things that we've done, I'll share with you just now, that will obviously increase the numbers. But on our database, I think we have about 25 million. So if you deduct the 17 from the 25 from the 17, about 7 or 8 million inactive members.
25 from 17, that's about 8 million.
About 8 inactive members, but they are on our database. But we do have 17 million active membership currently on the scheme. Now, again, this is where I also still talk about reforms. So you know that everyone pays for the NHIS, all right? Because if you buy something, it's
you're paying for it.
Yes. And for net contributors, we deduct from their salaries. Then they have to now register with 8 Ghana cedis before they become members of the scheme. So the board took a decision, I think last week, to abolish that 8 cedis so that net contributors will be automatic members of the scheme and benefit from the scheme. That will actually be increasing our membership straight away. Because, in fact, if you look at it, see, they will take car, go to our facility to register with 8 cedis, so they are even spending more. But at the end of the day, they also pay huge sums in terms of the direct deductions. And once we're able to bring in the Ghana card reforms, then it will be taken at source. So you do not really need them to be paying the 8 cedis. So those are the things that we are doing. So we believe that very soon the numbers will obviously, and also again, I mean, in terms of the expiry date, the cards as being going out of date, those ones to me are necessary because we can do it from our end. Once we have the Ghana card, what will be the point of the renewal? So we'll be doing automatic renewal. And this is where the digitalization agenda of the government is good. Because you see, the Ghana card lasts for 10 years. Our card was lasting for 5 years. You get the drift? Yes. So in this sense, I think it is really good that we are obviously abolishing that 8 cedis for the SNIT contributors. Its impact on our budget is negligible, trust me. So we don't have to put the SNIT contributors, and they are not that many. There are about 2 million of them or something. So they are not that many.
In terms of digitization, though, in which direction do you think the NHIA, and by extension the NHIS, is headed? How much more can we do with digitization feeding into digitalization?
I think for us, we believe that all our documents should be digitalized. And linking it to what the ministry is doing, electronic records, and so that we abolish all the manual things that we do. I think we are doing well in that regards because most of our claims now are digitalized. And we are using a lot of digital platforms like my NHIS app is also doing well. So once we do the Ghana card and we do the integration with the NIA, I think it's going to be fantastic. And again, there's one thing that I have to mention. One of the things that we are bringing on board is also the case that our visitors coming to this country must have mandatory health insurance.
So now we're getting to the point where we'll mimic what has applied in other countries. When you're traveling to other jurisdictions, you will need to get insurance before you get there.
It's very important. You know, I lived in the UK. You see, when you travel to when you travel there and you are sick, you need to benefit from the NHIA.
Right.
Okay, there. So it's the same thing. Visitors come. In fact, it's covered in our act that the non-Ghanaians must be covered. So I've seen a situation where some of my friends have come to this country and they are sick and they are calling me, which facilities do we go? So what we're doing is that once we give them mandatory visitors insurance, then it means that we designate facilities for them. So when they come and they are not well, they can go there. In fact, that can also bring additional resources to the NHIA, and which is really fantastic. It's also a case of expanding the scheme. And you know, the Ghana card will also be issued to non-Ghanaians. So once we do that, it is all towards achieving the universal health coverage. For me, it's very good. And I think those are the things that we must be focusing on. And I'm excited that obviously all these things are coming together for the government.
All right, let's look at some other health areas. You've spoken about the childhood cancers. Are there any other cancers that are being targeted as of now?
Yep, okay.
What's the plan?
So the breast cancer, as I said, is already covered. The cervical cancer.
When you say it's covered, what do you mean?
The treatment is covered. So, but I've told you about my preventive approach. So for me, in the medium to long term, the preventive approach in terms of screening those should be brought on board. To the extent that I believe that HPV, we must be able to do...
Did you just say HPV?
HPV.
Human papilloma virus.
It must be screened as some. So in the immediate to long term, we must be considering that. And the pap smear test, we must also consider that. Then I think there must be some labs on the medium to long term as well. But the main thing is we need to start somewhere. Once you start, you see that you now get a clear picture of how you need to. It's like the curative service. We didn't just add on the things. We only started and we kept on adding. In the same way that when we start with the preventive, because preventive is also broad, and almost all the diseases, we need to prevent them. So once we start in this way, then we can be adding on as we go. And like I said, if you put it in 5 to 10 years, you'll see a drastic reduction in terms of the claims, and you see a lot of cost savings. But in doing so, see, there must be other things that must go with it. So, for example, I will encourage Ghanaians actually to take physical activity very serious. Because at the end of the day, when you wake up, just do some small exercise, just be stretching, at least 30 minutes of walk. Go to the gym, go to the Bree Mountains, just be walking. You see, those are the things that we need. Eat good nutrients. In the UK, we have what we call 5 a day. Okay, it's not just by accident. So how can we also promote that in this jurisdiction? Fruits.
What you're saying is great, but if people end up eating a lot of carbs, it's also economic. You know that. I mean, these are real life issues. Recently, we had some, kidney patients in the studio receiving dialysis, and that's what I'm going to.
No, I get you. I think you are right.
It's also that. I mean, have you checked the cost of fruits on the market? So, especially organic ones nowadays.
What are we doing in support of our farmers?
People are afraid because there's galamsey and all that. If you're not careful and you're not careful where you buy from, fruits, vegetables. I mean, have you taken a look at the cost?
I get where you are going, but again, you see, how do we support our farmers in such a way that they bring more fruits? You get what I mean? So these are the areas that the Planting for Food and Jobs must also be looking at in terms of, because I mean, these are things that we need. Right. You see, so I think it's in fact, have you heard the phrase health in all policies? So the whole world is championing what we call health in all policies. So there must be health in agric, and it's exactly what we've just talked about. There must be health in economics. So there must be, finance ministry must have a health component in assessing their budget, in assessing their physicals. Right. You see, so those are the things. If you look at environment, there must be health in environment. So that is what we call the health in all policies, and it's an agenda being championed by the whole world. And this is what will actually near to the benefit of the ordinary Ghanaian. So a holistic approach for the whole system, talking to each other, is very important.
Important points made, even in trade.
In trade,
you can put it there in terms of the goings and comings and bringing in crucial logistics for health. Which brings me to the point of dialysis. I want to stay here for just a bit. It's becoming a major problem, kidney-related diseases. We've spoken about part of it because if people were checking, for example, their hypertensive levels more, you would know. If people were checking blood sugar more, people would probably not have degeneration into kidney disease. But what exactly can be done about dialysis treatment, for example? I hear the actual figures are north of 700-800 cedis, that there are some considerations that some groupings, I think First Sky, Ascolebu, AIDS and all that, but even the 400-500, people simply, I mean, how much is the person earning? What is the direction of the NHIA on that?
Okay, thank you so much. I think dialysis is a very important topic, and it's become topical in the country for some time now. And I think from us, from the NHIS, we don't just add on the diseases. Currently, there is a whole stakeholders and committees working on the actual impact on dialysis. Should we add on or should we not add on? But in the interim, luckily, when I came, when we were going to Parliament, it was also topical. So what we did was we obviously informed our MPs through the health committee that we believe that we must be able to champion some of our corporate social responsibilities on helping or supporting dialysis patients. Gratefully or graciously, Parliament gave the National Health Insurance Authority 2 million Ghana cedis as a subsidy as we wait for the actual actuarials for the entire dialysis scenario. So at the moment, I can confirm that the Ministry of Finance has actually given us the 2 million to disburse to support as a subsidy for the dialysis.
2 million Ghana cedis.
2 million Ghana cedis.
How are you disbursing this?
So,
which entities are getting it?
So again, there was a committee that was set up, chaired by Dr. Nsiasari. We are meeting this afternoon as well with all the CEOs of the teaching hospitals, the main ones, Kolebu, Komfo-Anokye, and Central Region. Let me say,
how about Tamale?
Yeah, Tamale, we've actually written to Tamale as of yesterday, and Ho, because we need the figures. But the figures that were given to us were from these three. That's
so it means as of now, the focus is going to be Kolebu, Komfo-Anokye, and the Central.
Yes, but there will be, once we get the figures from Ho and Tamale, we will.
So you are going to add them on?
Of course, we will.
They will not be.
No, they will not be left out. We just need the figures. So, like I said, as of yesterday, we've written to them. And what I know is that for Kolebu, as you said, there is a philanthropic supporting them for about 380. But during the conversation, as in the committee...
I hear is it twice a month or something of the sort?
Yes.
So it means in those 2 sessions, and some of them, they should be doing maybe 2 or more sessions. Some are doing 1, others are doing the 2. But it means in a week, your support has ended, and for the rest of the time...
Let me take my time to explain.
Because that's what some of them came in the studio
Let me take my time and explain it, because it's a little bit technical. Like I said, Kolebu is getting support from the philanthropists. But through the committee's meetings, we realized that the fees and charges have actually gone up from 380 to 490. Right. That is what we were informed. I don't know if it's factual or not.
I think 381 to 490.
Exactly, but that was the information we got at the committee level. So
Which is what I was told a few days ago when they were
So we decided that based on the numbers that we have, let's look at what is feasible, because it's only a subsidy. And let me put it clear, it is a subsidy. So what we decided to do is, if Kolebu is getting 380 for 8 cycles, that is each of them, they do need between 6 to 8 cycles per month. Or sessions per month.
Right.
Okay.
But hold it there. I get where you are going, but I just want to clarify, because that's not what the renal patients told me. They say it covers about 2 sessions. It's 2 sessions within an 8-session cycle, which is a month, that are covered. So you are saying here that all 8 are covered?
No, that's not what I'm saying. Okay, what I'm saying is that I know that there is a philanthropic support for Kolebu, but what can we as NHIS do? What I'm saying is that I know the patients do need at least 2 sections a week.
Exactly.
So it means that they need 8 sections for 4-week period, which is 1 month. They need 8. So even if the philanthropist is covering 2 sections, okay, that's for Kolebu. So for NHIA, can we bridge the gap for the 2 sessions between the 380 and 490? 1 or 491. When we worked it out based on the numbers, we were looking at 111 per section to make it 491.
Right.
So if we cover 2 sessions, it means it is 222. So at the end of the day, patients from Kolebu, based on the philanthropic support, are also getting 2 sessions free of charge at 491, based on the support that we are also giving them. Then you come to Komfo-Anokye. They do not have any support. But it's only fair that we cover the 491 for them, so that they are at par with Kolebu.
Right. So for them, Kolebu is not full coverage, but for them, I mean coverage in terms of session. But okay, so let me get this clear. Apart from what First Sky may be doing, you are topping up with the 111. Is that what you're saying?
Correct.
Okay, so they'll end up paying, they'll still stick to the 380, or it will reduce even further to the 200 and something you mentioned?
No. So if you add 111 to 380, it's 491.
Exactly.
For one section.
Right.
So it means when we give them...
But that is even after the subsidy already from First Sky.
No. So again, that's why I'm saying it's technical. So take your time to understand.
No, I think it's pretty simple. They say that the real figure, just so you understand me, is north of 700 cities.
But you cannot. But
that is the actual figure. Again, when you take out the subsidy of First Sky,
let's be careful.
That is when you end up with a 490.
Let's be careful here. We operate under law. Okay, Parliament under the fees and services is saying that it's 491. So who dare you charge more than 491? If Parliament have actually approved 491.
But even the 491, is it approved? Because there's been a tussle with Parliament and not even approving that.
That's what I'm saying. Okay, so we can even stick to the 380.
Right.
So if Parliament says that spend 380, you dare not spend above the 380. You get what I mean? So what I'm just trying to say is that let's put it into the approved figure. I am aware that under the fees and services, obviously there's 491 somewhere. As for whether it's in contention, I don't know. But what I know is 491. What the NHIS will do for patients from Kolebu is to top up what the philanthropist is doing, which is the 380. So we will give them 111 in addition. And we can only cover 2 sessions, which is 222 for all patients on the philanthropic support for Kolebu.
Okay, so
that one we can
just clarify for me. So for Kolebu, those going to Kolebu, how much, in essence, when this is through, how much are they going to pay?
It's 222
per each session, or per the two
sessions that we are. That it's just a top up.
All right. So then for the remaining sessions, so instead of paying maybe 380, they're now going to be paying 222 thereabouts. Is that what you're saying?
No,
for those 2 sessions.
No, they are not going to pay anything. In fact,
they'll pay nothing.
They'll pay nothing.
Okay, so that's the clarity I want. So for those 2 sessions,
the 2 sessions, because the philanthropist is paying,
and you are also
and we are topping up. So why would they pay anything?
Okay, so 2 sessions out of the 8 free. Yes. They are left now with 6 sessions.
Yes, already they were going to pay obviously the difference plus this thing.
So likely you can even say that what they would have expended on those 2 sessions to match up what the philanthropist is doing, they can now extend to the next 2 sessions. Okay, great.
But again,
now let's come
from Kolebu, Komfanoche. So we are giving them 2 sessions free for 491. So they will be getting 986 or something. Just do the math for me. 491.
So 400 by 2 is 800. 90 by 2 is 180. So that's what, 982 cedis.
982. So they will get it for free. Then patients from Central Region will get same. And again, you see, if you look at it, this is for equity purposes. You see, for NHIA, we thrive on equity. So we're just trying to make sure that, so in effect, patients from Kolebu, Komfanoche, and Central Region are getting 982 for free.
So you're now pegging all of them, because in the past, it was as though those in Kolebu were getting more benefits. Now you're putting all of them on par or at
based
par.
on the funds we have. At the moment, we don't cover it. We are only doing it as part of our 20th anniversary from our corporate social responsibility. So we don't cover dialysis, it should be clear. But based on our compassionate grounds, we believe that we must be able to do something. So the 2 million, as part of our 20th anniversary, and with the approval of Parliament, we are giving them that support.
So clarify, is that to say that all these, teaching hospitals are going to have similar packages?
Yes, when we get the data. Yes, I've already spoken to, I think, Tamale CEO, so I'm waiting for the data. And if you do the maths, there will still be, based on what I've shared with you, there will be some extra, and we'll go to Parliament mid-year. So when we go and there's obviously top up, we will obviously ask them to still cover it under our CR's corporate social, so that we'll be able to extend it to...
You say this is not, technically it's not part of your mandate, so to speak, or what you've been doing.
Yes.
You are doing it on humanitarian grounds.
Yes.
But I'm going to push you a bit.
Yeah.
Across the world, you keep mentioning the UK. They have the health system, especially for the vulnerable.
Yeah.
It's not for the rich. In fact, sometimes they take from the rich so that they can give proper health care to the poor. Here's what is happening. Back then, you would say, oh, a situation, and that is a bit of a misconception because we think it's when you consume a lot of sugar that. But some of these illnesses were deemed to be for a certain category of people, some elite people who ate certain foods. Now, if you look at, you can go back and look at that interview I had with the two gentlemen. They are not, they're even struggling for work. The common man is going down with diabetes. The common woman, you know, the ordinary Joe or Jane, is also now coming up with all of these conditions. Should we, are we, under your watch, going to get to the point where we look at this no longer as, oh, we are doing you a favor, but this is actually part of our core mandate? I mean, you react to the critical issues as they come up. Kidney disease has become a critical issue. Are we going to get to that point?
I think, so again, you see, if me and you sit here to say that we should add kidney disease to the NHIS, we'll be making a big mistake. But again, I get the drift. You see, there must be some sort of funding for kidney disease, okay? But as to whether it should come from the NHIA is the question that the experts must tell us, the actuarials must tell us. You get what I mean? Because we are also looking at the sustainability of the scheme. But what differently can we do? I believe that, you see, where we are, okay, we must be obviously buying equipment, for example, for health facilities in such a way that they will be able to reduce the cost of dialysis. That area of our mandate as NHIS, we've not actually explored it very well. So access, okay, and access can be defined in so many. So in some countries, you see, they buy these equipment in such a way that the cost of dialysis or the cost of certain diseases are reduced. Because if you have, let's say, the equipment, then it will be the cost on the consumables, basically. But some of the facilities do not have those equipments.
And even those that have, Kolebu, how many do they have?
Exactly.
So people actually have to wait in queue.
In queues. So you see, these are...
And this takes about, what, 4 hours or so? Because they are basically pumping your blood out,
so
cleaning,
when I talk about the
so
reforms,
to speak, and pumping it back in.
When I talk about, these are the things that I'm talking about. You see, into the future, how do we envisage ourselves to help in such a way that the dialysis patients will actually benefit from at a low cost? Because most countries, patients pay for the dialysis, but it's the amount that they pay. You get what I mean? So
vis-a-vis, for example, their PPP and the standard of, you know,
so I think I get all the points that you are, and these are good points that we must obviously take into account going forward. And these are the things that I'm prepared to have a conversation and see how best we will take this forward. You see, it's not a matter of, okay, NHIS should cover this, NHIS. Now, even if you say you are setting a separate fund for kidney cancer, what about diabetes, hypertension, stroke? They will be coming. So you see, there must be a holistic approach. It's not just a case of just talking, I'll set a fund for cancer, I'll set a fund for kidney, as people are advocating. You see, once you do that, the others will come for you, set a fund for this. So there must be a concrete...
But I do agree. You see, policy must be, it must feed into one another. It can't be, you don't have a hanging policy. A policy is not an island. If it doesn't feed into others, like you said, with the Ghana card and the NHIA, those are the synergies that are needed to ensure that you don't have a hanging, and that's why I feel we still need. But you see, I don't have a kidney-related issue, at least as of the last time I checked. But you look at some of them, and you can't help. There are times I've watched some, and you want to cry.
Yeah, that's true.
Our dialysis crisis, Maxwell Agbagba spoke to a woman. She basically broke down, calling on the president, calling on Ghanaians, because they are dying day by day. And sometimes you see your colleague and you can tell that, this person's face is puffy. This person hasn't had money to go for dialysis treatment for a while. And it's not even just the dialysis. There are medications they take. Some you see that this person, we're around the same borderline, and this person is gone.
Yeah.
Am I next? You know, these things are heartbreaking, and
Yes,
these are places where
I agree.
any country should be coming through. Because if you can't protect the vulnerable, then in essence, what are you doing? So I get all the points you're making.
I agree.
But
I agree. I think
more ought to be done.
For me, the patients, to me, the feedback I get is they are happy because, you see, half a loaf is better than none. But again, I still believe that more should be done. I agree with you perfectly. And this is why I believe that we must tackle it holistically, as I have explained over and over, because that is what I believe is the solutions to all these crises that we are facing, not only for dialysis, but for the other diseases, okay? So I think, yes, we must be able to provide the support that they need for them. That one, I agree with you. But again, we are also constrained in certain aspects. So let's see how we deal with it going forward. But our subsidy will go a long way to help them, as we still continue conversations with government to see what else can be done. But I believe that, and again, I commend the finance minister. You remember he donated some of the equipment in Tamale. You saw, yeah. And I mean, and this is where I also call on the private sector to also come in and see, because in some countries, you see, it cannot always be government. We need them. We need them. It should be. In fact, philanthropic support in countries like the UK, the US, is really real. You see, the Melinda Gates, they are donating. So where are the billionaires in Ghana? They must be able to donate some of these to support the...
Should I tell you? Should I tell you?
Well, I don't know, please. Let's know. I'm only calling.
Oh, I want to tell you.
To support.
A lot of them are buying fancy cars and living.
So they must come. They must come along and really support, because I think that, to say, we must be sensitive to some of these things, and I believe that government, private, and also philanthropic, corporate Ghana must be able to come in and support in times of need, because we must be taking care of our vulnerable. Like I said, we cannot leave the vulnerable in distress.
Let's talk about innovation before we cap off the conversation. Innovation is basically every day you must innovate. Some say you must run as fast as possible just to stay where you were yesterday. And in different facets, but also, for example, in building up the number of subscribers, because as more people latch on, I mean, different dynamics. How are you innovating so far, and what are your prospects for the future?
Thank you. As you can see, all the things that I've talked about,
they all feed
novel. You see, and I mean, though I must say that some were ongoing, but you see, I've just amplified it in such a way that it will really come along to support. Innovation is good. And I think it's just a case that we must continue to obviously support the innovation. It's not that you've just said it as new or novel, but there must be the stakeholders also supporting it in such a way that it gets successfully implemented, or comes to friction, or it becomes a success. So for me, the NHIA at this point is innovating based on the reforms that are being, and we are more people-centered, and we believe that these new things that we are bringing on board, when it's supported by all stakeholders, including the media, the development partners, and our clients, and the Ghanaian people, it will go a long way to change the overall architecture of healthcare delivery in the country.
I'm interested, though. This thought just came to mind. I know it is in the domain of the Ministry of Health and the Ghana Health Service, but do you have anything to do with vaccines, for example? And I ask that from the perspective of, you know, cervical cancer, for example, has a vaccine. And now malaria also has its own.
Great.
I ask from those angles. Are we looking at vaccines as well?
Yep, you are right. In fact, we do provide funds to some of the counterpart funding for the vaccines. If you look, the Ministry of Health do have about 10% of their budget on the NHIA. And those are the areas, so the vaccines and the counterpart funding that we provide. But again, yes, you are right. Those ones also fit into, because vaccines are also preventive. So those are the things that we really need to integrate properly on the NHIS in such a way that we are getting the full, do you get what I mean? So I think it will come along. I mean, like I said, let's start from somewhere. All those things will come along. But I must say that the vertical programs are also helping. They are helping a lot. So that's the immunization program from the Ghana Health Service is actually helping a lot, and the other interventions. So we do support those vaccines as well. Commodities, actually, commodities, basically.
I would take your final words, but before that, we wish you the best, because health is crucial to any country, and we wish for better times. Sometimes when we bring some of you here and we put you on the spot, it's not because we enjoy it, but because we want to get thoughts percolating on the crucial issues so that the generality of Ghanaians can benefit from what we ought to be benefiting from. Sometimes I look at some things and feel Ghana has no business being here if some things were being managed properly. Final words, Dr.
Okay, so I think I thank you for inviting me, but again, I must say that we need the support of the Ghanaian people in obviously implementing these reforms that we are introducing. At the end of the day, we are here to serve the Ghanaian people, and the NHIS will actually do exactly that. There are things that we believe that are not going well in terms of illegal payments in our facilities. We will plead with facility heads to actually put a stop to it. We know the challenges that they are facing. We are on the table dialoguing. So at the end of the day, let's dialogue well. Let's make sure that we review the tariffs in such a way that it will inure to their benefit and also to the benefit of the patients. But we don't believe that if we have a contract with you, and even if we are not able to meet, definitely we'll pay. So you do not need to, obviously, charge the patients. Let's put the patients first. And come back to us and say that, okay, you have incurred this, and we reimburse.
Dr. Aboagye, we'll sew it up here. We're grateful for your time, and we wish you the very best once more. That is Dr. Dacosta Aboagye, the CEO of the National Health Insurance Authority. Stay with us. There's still more action to come on the AM show. We'll also try to get you that feed as the Finance Minister, Dr. Amin Adam, addresses the nation on the state of our finances and more. You want to stay for that. We'll be right back on the AM show.